We are taking a sequential, systematic journey through medical imaging. Specifically, we're looking at the human brain under duress.
And we've got a series of 11 distinct, non-contrast CT demonstrations queued up to do exactly that.
Yeah, 11 scans. We're skipping the fluff completely and diving straight into the stark grayscale reality of neurological emergencies. We want you to understand exactly how these pathologies are decoded in real time.
And to do that effectively, you really have to adopt the systematic approach of a radiologist or a neurologist.
You can't just glance at the film, right?
No, you don't just glance at it and wait for a lesion to jump out at you. You interrogate the image from the outside in.
From the skull inward.
Precisely. You evaluate the calvarium for fractures, systematically trace the parenchyma to confirm gray-white matter differentiation, assess the ventricular system for effacement.
Checking midline structures for any shift. Yes, and meticulously clear. The basal cisterns, the extra-axial spaces, and the posterior fossa. That rigorous, reproducible framework is really the only way to reliably catch a subtle, life-threatening crisis.
Okay, let's unpack this, starting with our baseline demonstration.
Oh,
Scan 1.
the foundation.
Right. This first non-contrast CT is the gold standard of a healthy brain. I mean, the calvarium is completely intact.
No fractures.
None. And looking at the parenchyma, the gray and white matter differentiation is perfectly preserved. The ventricles are normal in size and contour, there's absolutely no midline shift, and we have clear basal cisterns without any abnormal hyperdense or hypodense regions.
What's fascinating here is that this image of flawless symmetry is your most important diagnostic tool.
Because it sets the standard.
Exactly. You cannot spot the abnormal until that perfect anatomical map is burned into your visual cortex. Radiologists are constantly hunting for deviations from this baseline.
Like hyperdense regions. All right, the bright white spots indicating acute hemorrhage or calcification, and conversely, the dark hypodense regions suggesting edema or infarction. Without a deep internalized understanding of exactly where the sulci should lay and how the ventricle should align identifying early pathology, it's essentially impossible.
So what happens when that perfect symmetry shatters? Moving to scan 2, our next demonstration. The baseline here is completely disrupted.
Such a dramatic shift.
It really is. We're looking at a localized, sharply defined hyperdense lesion right deep within the right basal ganglia.
And notice the edges.
Yeah, immediately surrounding this hyperdensity is a distinct hypodense halo. It clearly indicates perihematomal edema.
That is a textbook acute intracerebral hemorrhage. The location alone is incredibly high yield for clinical diagnosis.
Because of the basal ganglia involvement.
Yes. A bleed specifically isolated to the basal ganglia is overwhelmingly driven by chronic, poorly managed hypertension.
High blood pressure.
Decades of it. Decades of high systemic vascular pressure relentlessly battering the lenticulostriate arteries.
Those are the tiny, deep, penetrating vessels, right?
Right. And this sheer stress leads to the formation of Charcot-Bouchard microaneurysms. When one of those microscopic weak points finally gives way, the arterial pressure forcefully dissects the surrounding parenchyma.
Resulting in that dense, hyperdense hematoma we see on scan 2.
Exactly.
Now, that isolated bleed is a stark contrast to our next demonstration scan. This shows a catastrophic failure of the same system. Here we see a massive hyperdense hemorrhage. The sheer volume of the extravasated blood is staggering.
And that hypodense halo of edema is aggressively expanding.
It's taking over.
We are looking at a severe high-pressure crisis dictated by the Monroe-Kelly doctrine.
The fixed volume problem.
Yes, the cranium is a rigid, unyielding vault. It contains brain tissue blood and cerebrospinal fluid. If you rapidly introduce a massive new volume like this expanding hematoma, the pressure skyrockets.
Because the skull literally cannot expand to accommodate it.
Right. This creates a severe mass effect. In this specific image, the mass effect is physically herniating the brain's midline structures over to the right.
And it hasn't just shifted the midline, the hyperdensity has actually breached the ventricular wall. We have clear intraventricular extension here.
Which is exactly the kind of complication that turns a dire situation into an immediate battle for survival.
Blood spilling into the ventricles.
Yes, when the hemorrhage ruptures into the lateral ventricles, it disrupts the normal circulation of cerebrospinal fluid. This often leads to acute obstructive hydrocephalus.
So the fluid backs up.
And the pressure climbs even faster. In the emergency department, the logistics immediately shift toward heroic measures to manage that exponentially rising intracranial pressure.
Often requiring urgent ventricular drainage?
Correct.
From the hyperdense pressure cookers of active bleeds, let's pivot to the exact opposite pathology. Here, the hyperdensity is completely gone.
Replaced by a void.
Right. Instead, we have a massive wedge-shaped hypodense void involving the entire left frontoparieto-temporal region.
It's very dark on the scan.
Very dark. The gray-white matter differentiation is completely obliterated. This is a massive ischemic infarct mapping perfectly to the territory of the left middle cerebral artery.
The MCA. It's the primary workhorse of the cerebral circulation and overwhelmingly the most common site for major ischemic strokes.
So what's causing that dark void?
When a thromboembolism occludes the proximal MCA, a vast swath of the hemisphere is immediately subjected to profound hypoxia. The cells fail to maintain their osmotic gradients.
They start taking on water.
Exactly, leading to rapid intracellular swelling or cytotoxic edema. That dying swollen tissue is exactly what registers as that dark hypodense void on the CT.
And looking at the ventricles, the swollen tissue is acting just like the mass effect we saw with the hemorrhage scan. The cerebral edema is severely compressing the ipsilateral lateral ventricle and driving a dangerous midline shift.
Which is a critical mechanical point to understand. A stroke isn't just an absence of blood flow.
It's a physical mess.
It is the creation of a swollen, space-occupying lesion. The necrotic tissue expands, driving intracranial pressure up just as lethally as a hematoma.
Often leading to fatal herniation syndromes if the edema isn't medically or surgically managed.
Exactly right.
But the clinical presentation of an infarct is entirely dependent on the vascular real estate it claims. Let's look at scan 5.
A different territory.
Yes, the shifts away from the MCA territory. We see a well-defined hypodense region in the left parieto-occipital area, specifically isolated to the posterior cerebral artery territory. The midline shift here is minimal compared to the MCA infarct.
The location changes the entire clinical reality for the patient. An MCA occlusion typically presents with profound hemiparesis, facial droop, and often devastating aphasia if it strikes the dominant hemisphere.
But the PCA is different.
Very different. The PCA supplies the occipital lobe, the visual cortex. So PCA infarct manifests with highly specific visual deficits.
What specifically?
The classic presentation is a contralateral homonymous hemianopia.
But they lose half their vision.
Right, the patient completely loses the right half of their visual field in both eyes due to the left-sided cortical damage.
You're spot on about the visual deficits, but what catches a lot of clinicians off guard here isn't just the blindness, it's the patient's complete unawareness of it.
Anton syndrome.
Yes, you often see Anton syndrome with occipital damage, right, where the brain actively denies that it can't see, and the patient will confidently confabulate their visual surroundings despite being cortically blind.
It is one of the most remarkable and frankly unnerving neurological phenomena we encounter. The damage isolates the visual cortex from the brain's speech and reality monitoring centers.
So the brain just makes it up?
The brain, abhorring a vacuum, simply invents the visual input. It perfectly underscores why mapping the exact anatomical boundaries of the hypodensity on the CT is so vital. It predicts these complex, seemingly paradoxical clinical behaviors.
Here's where it gets really interesting. Moving from deep parenchymal lesions, let's examine extra-axial hemorrhages. Surface bleeds.
Scans 6, 7, and 8.
Right. On a CT scan, the geometric shape of the blood pooling against the inner table of the skull tells you exactly the underlying hemodynamics of the injury. Let's look at scan 7 first.
The epidural.
Yes. In this demonstration, we see a hyperdense collection along the right cerebral convexity. But the shape is striking. It bows inward toward the brain, forming a perfect biconvex lens.
A very distinct shape.
And crucially, the margins of this lens stop abruptly at the cranial suture lines.
That biconvex lenticular shape is the absolute undeniable hallmark of an epidural hematoma.
An EDH.
Yes. The physics of this injury are brutal. It almost always involves blunt trauma to the temporal bone, which fractures and lacerates the underlying middle meningeal artery.
An arterial bleed.
Because it's arterial, the blood is pumping out under high systemic pressure. It acts like a hydraulic wedge, violently peeling the tough duramater away from the inner table of the skull.
And it stops at the sutures because the dura is so firmly anchored to the bone at those fusion points. The arterial blood can't easily dissect past them, so it has nowhere to go but inward, compressing the hemisphere into that lens shape. The clinical history that accompanies this specific geometry is notoriously deceptive.
Deceptive and incredibly dangerous. Yeah. The classic presentation features the lucid interval.
They seem fine at first.
Right. The patient suffers a blow to the head, perhaps loses consciousness briefly, but then wakes up. They might be walking, talking, and acting completely neurologically intact.
But it's an illusion.
It's like the calm eye of a hurricane. Inside the closed vault of the skull, that arterial bleed is rapidly expanding. Once the hematoma reaches a critical volume and the brain's compensatory mechanisms are exhausted,
The pressure just overwhelms the system.
the patient experiences a catastrophic, precipitous drop in consciousness, often rapidly progressing to a fatal uncal herniation. It is a terrifying race against the clock in the trauma bay.
Now compare that high-pressure biconvex lens in scan 7 to our next demonstration, scans 6 and 8.
The subdural hematomas.
Right. Let's focus on scan 8 for the pure shape. Here we see a hyperdense extra-axial collection on the right side, but the geometry is entirely different. It forms a long, sweeping crescent shape that seamlessly crosses the cranial suture lines tracking along the entire hemisphere.
That crescent shape instantly tells us we are dealing with a completely different vascular system. This is a subdural hematoma. It is caused by the shearing of the bridging veins that drain from the cerebral cortex to the dural venous sinuses.
So it's venous, not arterial.
Because venous blood is under significantly lower pressure, it doesn't hydraulically peel the dura away from the bone. Instead, it leaks into the potential space between the dura and the arachnoid mater.
Spreading out much further.
It spreads out diffusely, molding to the convex contour of the brain, creating that long crescent. And because it is deep to the skull's inner table, it isn't restricted by the dural attachments at the suture lines.
Which brings us to a crucial variation of this pathology in scan 6. We are looking at bilateral subdural hematomas, crescent shapes compressing both hemispheres. But the density is not uniform here.
It's mixed.
Yeah, we see a complex mixture of dark, hypodense regions interspersed with bright, hyperdense fresh blood.
This is an acute chronic subdural hematoma, and it reveals a critical clinical takeaway about neural anatomy and aging. As we age, our brain parenchyma naturally undergoes atrophy.
It shrinks.
It shrinks. As the brain pulls away from the skull, the bridging veins traversing the subdural space are stretched taut like piano wires.
So the mechanical tension is already incredibly high before any trauma even occurs.
Precisely. A trivial mechanism of injury, a minor bump on a kitchen cabinet that a 20-year-old wouldn't even register, can easily snap one of these stretched, fragile veins in an elderly patient.
And it bleeds slowly.
The vein oozes slowly. Over weeks, the initial hemorrhage degrades and liquefies, turning dark and hypodense on the CT. That is the chronic component.
But the danger isn't over.
Not at all. The bridging veins remain vulnerable in this expanded space. A second minor bump causes a fresh hyperdense venous bleed into that old hypodense fluid cavity.
Giving us that mixed density on scan 6.
Right. The underlying cerebral hemispheres are subjected to an insidious slow-motion compression that can easily mimic dementia or a slow cognitive decline if the imaging isn't scrutinized.
That slow creeping compression is a fascinating contrast to the explosive nature of our next case, scan 9.
A classic.
We are dropping down to the base of the brain, specifically evaluating the basal cisterns. Normally, these spaces are radiolucent, filled with dark cerebrospinal fluid.
But not here.
No, in this demonstration, the cisterns are entirely engorged with hyperdense blood. Because of the complex anatomy of the suprasellar and ambient cisterns, the blood traces a highly specific, jagged, bright white pattern at the center of the scan.
That is the universally recognized star sign. It's the radiological signature of an acute subarachnoid hemorrhage.
An SAH.
Yes, the blood is freely circulating within the subarachnoid space, mixing directly with the subarachnoid fluid. While severe trauma can cause this, the most feared spontaneous etiology is the catastrophic rupture of a Barry aneurysm.
Usually in the circle of Willis, right?
Very frequently located at the anterior communicating artery within the circle of Willis, yes.
Given how fast the hallmark symptom, the thunderclap headache, comes on, what's the immediate next step when you spot that white star on the non-contrast CT? You know there's a bleed, but the CT doesn't show you the precise vascular defect.
This raises an important question regarding clinical workflow. The non-contrast CT is simply the alarm bell. It confirms the presence of subarachnoid blood, but it cannot map the vasculature.
So you need a different scan.
The immediate non-negotiable next step is a CT angiography, or ideally a digital subtraction angiography.
To find the actual aneurysm.
You must inject intravenous contrast to map the arterial tree, pinpoint the exact location and morphology of the ruptured aneurysm, and rapidly intervene.
Usually through endovascular coiling or surgical clipping.
Before the aneurysm re-ruptures. The mortality rate of a secondary hemorrhage in these cases is staggering.
Let's transition to a completely different class of pathology for our final two imaging sequences, scans 10 and 11,
Leaving trauma behind.
leaving vascular emergencies and trauma behind entirely. Looking at scan 10, the parenchyma is peppered with dozens of tiny, sharply demarcated, hyperdense punctate lesions,
They're everywhere.
scattered diffusely throughout both the cortical and subcortical regions of both hemispheres. It legitimately looks like a starry sky.
It is a visually striking presentation, but what you are looking at is the radiological footprint of a parasitic invasion.
Neurocysticercosis.
Yes, those diffuse hyperdense dots are the calcified fossilized remains of Tinea solium larvae, pork tapeworm cysts that have permanently lodged in the patient's brain tissue.
And this specific scan 10, represents the inactive end stage of the disease process, right?
Correct, the calcified stage.
Which makes our final sequence, scan 11, so compelling because it captures the entire life cycle of this parasite as it plays out within the human brain. The imaging here traces 4 distinct evolutionary stages.
Starting with the vesicular stage.
Right, where we see clear cystic lesions. And inside several of these cysts, you can actually identify the hole with dot sign.
The dot being the hyperdense scolex.
The head of the living parasite.
It is incredible that we can visualize the actual anatomy of the parasite in vivo. As long as the parasite remains alive in that vesicular stage, it expertly evades the host's immune system, and the patient may be entirely asymptomatic.
But eventually, the larvae begin to die.
And that cellular death triggers a massive local inflammatory response from the host, which ushers in the colloidal or degenerating stage.
That's where the scan changes dramatically.
On imaging, you suddenly see intense ring enhancement around the cysts, surrounded by significant hypodense vasogenic edema as the blood-brain barrier breaks down locally.
Then the inflammation begins to subside as the cyst shrinks into the granular nodular stage.
Eventually culminating in the dense calcified dots of the starry sky appearance we just analyzed in scan 10.
And the clinical implication of those calcifications is profound, isn't it?
Very profound. In regions where Tinea solium is endemic, a previously healthy adult presenting to the emergency department with entirely new onset generalized seizures will very frequently demonstrate this exact calcified pathology on a CT.
Because the dots act like irritants.
Those hardened hyperdense nodules are highly epileptogenic. They act as permanent physical irritants within the parenchyma, short-circuiting the local neural networks and triggering sudden, unprovoked electrical storms in the brain.
What an incredible sequential progression we have just navigated through these 11 scans.
From normal to highly complex.
We established the gold standard of anatomical symmetry. We decoded the hyperdense hemodynamics of deep basal ganglia bleeds and the brutal physics of massive hemorrhages causing midline shifts. We mapped the hyperdense voids of major ischemic infarcts across specific vascular territories.
The MCA and the PCA.
Exactly. We contrasted the geometric constraints of high-pressure epidural lenses against the diffuse spread of subdural crescents. We analyzed the brilliant star sign of an acute subarachnoid rupture, and finally traced the life cycle of a parasite written in calcified constellations across the cortex.
A full spectrum of neurological emergencies.
So what does this all mean? It proves that a grayscale non-contrast image is far more than a simple anatomical snapshot.